Today, as Dr. Sherry mentioned, we'll be going over chronic fatigue and fibromyalgia, which are, that advanced a little too fast, which are two common chronic conditions that we find most in our office. And we already went over that. So the overview of the presentation will go as follows. We'll do basic understanding, some statistics of fibromyalgia chronic fatigue syndrome. We'll go over a little bit of the research, the mechanisms of how these conditions actually arise, manifest themselves within the body. Really, pain modulation is what we'll concentrate on, and that's rooted in the dysregulation or alteration of some of these brain hormones, concentrating on serotonin and, of course, hyperactivity of the brain. And then really, towards the end, we're going to go over effective strategies that have been proven in research and, most importantly, in actual practice. When I first started out, I was reading a lot of good research, and I found this miscommunication between what was studied and how it was applied. And maybe that was due to it being performed on animal studies, or possibly it just wasn't relating to the bio-individuality of the patients that I was seeing. So these great nutrients with these profound results were being displayed in these different peer-reviewed research articles, and it just wasn't working in practice. So I want to emphasize that everything we go over today has actually been proven in practice, whether my patients directly or some of the patients I've consulted on with other practitioners. So this is our society. We have a pill for every ill. I'm smiling on the outside because I have a rainbow of pills on the inside. And we have now begun to treat everything with some form of prescription. It doesn't matter how simple it is. It could be something like digestive distress. Of course, we'll concentrate on today. Pain is one of the big ones. And there's plenty of statistics out there that say after the second prescription, we have no clue the interactions that we're going to get in that particular patient. So we don't know the side effects. We don't know the positives or negatives from having this polypharmacy within the patient. So it's really important to find very effective alternatives for these patients. So we're going to use the abbreviations CFS and FM, CFS obviously for chronic fatigue syndrome and FM for fibromyalgia. And some loose estimates out there, about 4 million people in the US meet the criteria for chronic fatigue syndrome. About 85% of the US population, believe it or not, could actually meet the criteria, but they go undiagnosed. The syndrome will equate for about $9 billion annually in medical costs, and for any individual within a household that contributes to the income, you can lose up to about $20,000 a year in lost revenue from having this condition. So when we go through this, you'll see that the ideologies of chronic fatigue syndrome and fibromyalgia are very, very similar. But chronic fatigue syndrome presents with fatigue greater than 6 months, diffuse body aches, usually in the muscle bellies, not so much in the joints, some insomnia, and hypersensitivity to some sort of stimulus. Now, fibromyalgia is estimated to affect about 10 million people and makes up over 20% of the amount of money that America spends on pain. America spends about $65 billion on pain per year, and fibromyalgia makes up about 14 billion, or about 21%. And unfortunately, like many chronic conditions, females do wind up suffering from fibromyalgia more commonly than males. And that may have to do with hormonal fluctuations and how the brain perceives pain. So as mentioned before, these conditions, although may present slightly different in clinical practice, chronic fatigue, more fatigue than pain, fibromyalgia, more pain than fatigue, they will have these common origins. And we have cellular patterns of mitochondrial dysfunction, oxidative stress, of course, inflammation, ammonia excess, and what's termed multifocal dysbiosis, basically meaning different parts of the body have an imbalance of proper flora or possibly even pathogenic microbes like the dentition, the GI tract. And then we'll have these neurogenic patterns of central sensitization, which is really what we're going to concentrate on today. Central sensitization is really this hyperactivity of the brain, which then leads to hypersensitivity to the environment. So that soft touch now becomes a painful stimulus. And that has to do with alterations in neurotransmitters. So originally, to diagnose someone with fibromyalgia, you would actually have to physically see the patient. So this is a disease of a physical manifestation of pain. Yet in 2010, the College of Rheumatology decided that we no longer needed to have these tender spots. So we used to have to diagnose the patient with fibromyalgia with 11 out of 18 tender points. And now we only have to ask them a few questions, and we would grade them based off of these two scales called the widespread pain index or the symptom severity scale. So now that we've kind of got that out of the way, the basic statistics and what those two conditions are, let's really talk about what we're here for, and that's modulation of pain. And to do that, we really have to understand that pain is an emotion. It's a physiologic sensory experience. And this is interpreted by the higher brain centers. So it depends on the intensity of the stimulus as to whether or not the brain says, wow, that was painful, or that was friendly. So a hug versus putting your hand over fire. And when you look at the basis of central sensitization, you can start to see that the hyperactivity of the brain is really the crux of these two conditions and other pain conditions when you really dive into it. So this does not, this presentation and what I'm going to go over today does not just apply to fibromyalgia and chronic fatigue syndrome. We are using those as the prototype, but you can apply this to any condition that really the insult or onset or injury doesn't really match the patient's level of discomfort. I urge you to start to look into this dysregulation of brain hormones. So we have two major pathways that we're going to talk about. We have the pain pathway and we have the touch pathway. And depending on how the brain receives the signals, how intense the signals are, it will be interpreted as pain or touch. So in this scenario, we have some sort of noxious stimulus, a fire, a cut from a knife, maybe some sort of burn. That's a high intensity signal. That's going to be sent from the peripheral nerves all the way up to the central centers, and it's going to be interpreted as pain. This is normal pain sensation. Then we have touch. In this example, we have a feather, the stroke of a feather on an arm, a foot. That is a low intensity input into the nervous system, and that's going to be interpreted as just touch and not pain. Now, folks with central sensitization, we're going to have this increase in stimulus. So this feather now turns into a hammer, and that fire now turns into a blaze. And we get this hyperalgesia and this allodynia. So we have this same stimulus comes in, but now it's interpreted and it's multiplied by 10, 50, 100 times. And we're going to get this extreme pain that's going to turn into this widespread. So it's no longer going to be local. We're going to increase this receptive field. Something that was just on the hand is now going to feel like it's traveling up the arm. Now we move down to what used to be the touch mechanism or the touch pathway, and the shake of a hand or a hug, or I've even had some patients complain of their bed sheets actually being painful on their ankles or their toes. And we're going to have this hyperexcitation. So now that simple touch turns into some sort of nociceptive or noxious stimulus. This is the hallmark. This is the central dogma of why these patients have such high or such low pain thresholds with these seemingly minor insults. And I found this picture when I was searching through some research, and I found that this group of individuals wanted to figure out why people post-surgery were having this persistent pain. So a patient goes in for a surgical procedure. For all intensive purposes, the surgery is successful, yet 10 to 50% of the time, the patient complains of persistent pain. So we start to look at what is actually happening. And when you have this injury of a nerve, and that can be dietary injury, it could be neuroinflammation from eating poor fats. It could be infection, maybe like a herpes virus or some sort of bacteria. It could be a slip or a fall. It could be a car accident. Whatever injures that nerve, we're going to start the inflammatory process. And if you have inflammation, you have to have the immune system. Those two things go hand in hand. You have the immune system, you have inflammation. You have inflammation, you have the immune system. So with this onset, or with this original insult, you're going to get this influx of macrophage or white blood cell activity to the area. That's going to start this inflammation. We're going to get this bulbing out, or this neuroma formation. This neuroinflammation now, because we have the immune system there, is going to actually change the way these peripheral nerves are perceiving the signal. So they will amplify it locally even before it gets into the brain. So you'll change gene expression at a peripheral location due to this immune and inflammatory cascade. This will then lead to a reduction of inhibition locally, and that will then, almost like a microphone, amplify that stimulus. So if we go back to the previous example with the feather now becomes a knife. And that gets sent up to the higher brain centers in an amplified, high intensity fashion, which is then going to be interpreted as pain. That pain will then wind up, of course, altering a patient's mood, behavior, and we can actually start to see some different hormonal dysregulations from the neck down from having this central sensitization. So this will affect a whole lot more than just perception of pain. We'll start to see thyroid disruption. We'll see testosterone, estrogen levels start to alter. Pretty much all bets are off as soon as we start to have this pathway. And that's why you see these patients, you know, it may start as just a simple pain syndrome, or it may start as some sort of chronic fatigue. And then over the years, the decades, these people go without proper care. It just manifests and it builds and builds and builds. And now they're overweight. Now they have pain everywhere. They're having blurry vision. They can't sleep anymore. They're super depressed. And it all has to do with this central regulation. Now, central sensitization, once again, is not reserved for just fibromyalgia and chronic fatigue syndrome. We could see it in generalized pain, sleep disorders. We see central sensitization, IBS, chronic headaches, depression, anxiety. And really, we're going to have central sensitization because of two reasons. As mentioned previously, central sensitization in the simplest sense is hypersensitivity due to hyperexcitability. And we're going to see alterations or deficiencies in different brain hormones that will allow this to happen, and we'll concentrate on serotonin today. Another thing that can actually cause this process is this constant minor bombardment of peripheral receptors and that physical stimulus entering into the brain. Kind of think of this as, you know, you're sitting in class and you're taking an exam and someone is tapping their pen on the desk. You just have someone over and over tapping their pen. Maybe you can handle it for the first couple minutes, and then after a while that tapping starts to sound like someone's got a jackhammer and you can no longer function. The brain shuts down, you can't read the questions, and you're about to freak out. That's what happens in these patients. We're getting this minor nociceptive input over and over again into the system, which actually starts to create this inflammation, this immune cascade. And then we get what we saw in the previous example of alterations in the inhibition as well as central nervous system neurotransmitter imbalances. So as I said previously, it's really a different, it's ratios and balances, and that's life. That's every condition we ever look at. It's all about balance, right? So a male comes in and I have too little testosterone. So a traditional doctor just gives them testosterone. Well, maybe we should look at that patient's estrogen levels at the same time, since that's kind of a downstream metabolite of testosterone, right? It's about balance. If we have low testosterone and high estrogen, maybe the patient doesn't need more testosterone, maybe they need less estrogen. In what we're looking at here as it relates to central chemistry is we're looking at the balances of different brain hormones. And what you see in front of you is going to be the serotonin cascade, or basically how tryptophan can be metabolized in the body. And tryptophan has two ultimate fates. We have the one at the top, the blue line, which will take tryptophan to 5-hydroxytryptophan to serotonin. Then in the pineal gland, we'll make melatonin from serotonin. Or we can go down the red pathway, which is considered the kinurins. This is a altered alternative pathway of tryptophan. Now, it's not all harmful, but in these folks with central sensitization, they will have this one common factor. They will make too much of this acid down here, quinolinic acid. Quinolinic acid, as you will see, will actually cause that hypersensitivity. And if you have too much quinolinic acid compared to your serotonin, so if there's, you can actually do a ratio for these patients, and things like this can be measured in an organic acid test, which is a urine test, and you can actually look as whether to see if their brain is quote unquote on fire. Do they have this neuroinflammation foundation that will cause this hypersensitivity to non-noxious stimulus, the handshake, the hug, the bed sheets, the feather? Now, the question is, A, why does the body have this potentially harmful pathway? And B, how does the body increase this? Why are certain patients having too much of this acid and other patients seem just fine? Well, a couple different reasons. The immune system will actually utilize this red pathway. So different inflammatory proteins will actually upregulate this pathway. And some of these things aren't so bad, like kinuric acid towards the left of the screen right here. That can actually antagonize some of the negative effects. Then we have stress hormones. So different stress hormones can actually increase this pathway. And you may find, as when you talk to these patients that have these chronic pain syndromes, that they had a very stressful childhood, or they don't handle stress well at their job or their relationships or whatever it may be. So we want to look into that as well. Interestingly enough, as an aside, cancer cells will actually manipulate the availability of tryptophan. So if we lower tryptophan levels, we will actually reduce T cell function, which will allow the cancer cells to grow more rapidly and be able to survive longer. So one other note is that tryptophan is essential, so it needs to be consumed. We need to make sure our patients are consuming enough good quality protein. Now, if you see in this chart here that tryptophan can be stolen in either direction. We can make the serotonin in the blue, or tryptophan can go down the kinurin pathway. So if we want to increase serotonin in these patients that maybe have this dysfunction, giving tryptophan or having them just increase tryptophan in their diet may not be ideal, because we may make the situation worse. And we'll talk about what we want to do in those patients here in just a second. So we talked about why the body can actually increase that red pathway, that quinolinic acid, and that can potentially cause this hyperexcitation in the brain, causing that hypersensitivity. And one of the main reasons that can happen in individuals is the influence or stimulus that is received from the gastrointestinal tract. And I'm not going to belabor the whole gut-brain connection. There's tons of great articles out there. I'm sure there's plenty of great webinars and speakers about it. But I did want to mention this because this will be one of the things you will see that is about common in about 90% of the patients that come into your office with chronic fatigue and fibromyalgia. They will complain of some sort of gastrointestinal distress. It could be something as minor as gas and bloating. It could be alterations of diarrhea and constipation. It could be pain, it could be nausea. I would argue to say about 90% of those patients will have some sort of GI issue at some point in time in their life. And most of the time it's chronic. It's been since they were a little girl. They were always the sick kid on the block, or they had to miss a lot of school because their stomach always bothered them, or what have you. And the reason for that is there's a specific group of gastrointestinal microbes. They're gram-negative bacteria, and they have this LPS, or lipopolysaccharide, on their surface, and that will interact with the immune system. It's a virulence factor that these bacteria have to be able to infect the patient. And all they're trying to do is survive. Everything's trying to survive. Humans are trying to survive. Yeast, bacteria are trying to survive. Parasites, and that's all these bacteria are trying to do. And those lipopolysaccharides allow them to do that. But they are recognized by our immune system, and our immune system tries to fight them off. By doing so, it will increase the enzyme IDO, which will steal your tryptophan and make some more of the kinurins with it. So that is one way that the gastrointestinal tract can affect the way your patients perceive pain. That is one of the major gut-brain connections. And there is some pretty good research out there, a handful of articles at least that I found, that they will treat pain with antibiotics, which there seems to be no immediate connection to that. Antibiotics are just supposed to be to take care of some sort of living organism. But by taking care of these negative bacteria within someone's system, they are altering this pathway, allowing for more serotonin and less of that hyperactivity of the brain. And there's additional research out there as well that will look at these patients that suffer from these chronic pain syndromes and find a linear relationship between the level of dysfunction within the gastrointestinal tract and their pain levels. So it's some very interesting stuff. Now, I talked about previously of tryptophan having the dual fate. We could do the serotonin and the melatonin, or we can go down that harmful kynurenine pathway. And there's a time where we need to increase that serotonin acutely. Patient comes in, they're in a lot of pain, we suspect this central sensitization and or we have proof for it. We need to get the serotonin up while we're working on getting that quinolinic acid down. And giving tryptophan would be contraindicated, but what we can give is 5-hydroxytryptophan. So 5-hydroxytryptophan, it has an irreversible direction in its production or synthesis of serotonin. So it's not going to go backwards to tryptophan, which can then get sucked down that potentially harmful pathway. So 5-hydroxytryptophan could be great to give these patients. And we do also need to look into providing them the cofactors as well, because 5-hydroxytryptophan administration may not just do it. Especially if the patient has some sort of gastrointestinal issue, then they're going to probably have some imbalance in their macro micronutrients. So vitamin B6, magnesium, we actually need oxygen for this pathway, and SAMe or S-adenosylmethionine. And the amounts of those you can see here, 5-hydroxytryptophan, about 100 to 600 milligrams a day. Some cofactors, magnesium. Now, magnesium comes in a bunch of flavors, glycinate, threonate, malate, orotate, whatever you really want, but the dosage will depend on which form you're using. Some of the more higher bioavailable forms you can use less of, and vice versa for the lower bioavailable. Vitamin B6, about 25 to 50 milligrams a day, and we would want to look for the pyridoxal 5-phosphate form, the activated B6, and then S-adenosylmethionine, anywhere from 100 to 400 milligrams a day. One product I really like, I don't think gets enough attention, which is L-theanine. L-theanine is extracted from green tea. It reduces stress, increases brain alpha waves, and it can increase serotonin. And you want to dose that about 200 to 600 milligrams a day. Now, these can all be given together. You could try them in isolation. It really just depends on the patient and how they present. In the beginning, I usually try and group some of these together because it seems to be more powerful that way. L-theanine, as an aside, if you mix L-theanine with some caffeine, it really does improve brain efficiency and memory. So those of you who may be studying now, or you have patients that are taking a certificate for their occupation, or they're in school, they're college, high school kids, you can actually have them take L-theanine, which is extremely safe, and have them maybe take some green tea with it for the caffeine content, or some black coffee. So there's another neurotransmitter that we need to talk about, and that would be glutamate. Glutamate is going to be the major neuroexcitatory neurotransmitter in the central nervous system. And glutamate has this very intimate relationship with this blue receptor you see on your page here, NMDA. Now, NMDA and glutamate, or glutamate will find the NMDA receptor. This will then open up calcium channels within the neuron and allow calcium to move in. Now, this will cause a tremendous amount of firing of the neuron due to the mitochondrial function. And if you continue to fire the neuron over and over again, you eventually will get cellular death. So we get that hyperexcitation followed by necrotic tissue from the cell dying. So we have cellular debris. Not only do we get the excitation, but now we have an immune response coming in to try and clean up all of these dead dying cells that have kind of been overworked and underpaid for so long. So we just perpetuate the problem over and over again. If, in the beginning, this may just lead to this phenomenon of central sensitization or increased pain levels. But if you let this go on for decades, this could possibly be a mechanism for dementia, Alzheimer's, or other cognitive issues because we are having so much immune activity within the brain. So this could be something to look at for a lot of different patients, not just those suffering from chronic pain. So if we can modulate or we can kind of step in and say, hey, glutamate, I don't want you to bind so strong. Now we need glutamate, so we don't want to get rid of it completely, but how can we slow or reduce its affinity for the NMDA receptor? We could do a couple things. We could try and lower glutamate. One of the most effective ways of lowering glutamate to more of a normal physiologic level is to control a patient's blood sugar. So glutamate is going to be efficiently created in high sugar environments. So we want to make sure that we're always checking patient sugar levels when they come in with some sort of chronic pain syndrome, because that can actually create hyperactivity in the brain. Even those patients that suffer from anxiety or the brain overworking, or they lay down at night and they say, you know, all my brain does is race and I can't go to sleep. I would urge you just a real cursory glance at their sugar levels, and you want to do that with HbA1c, fasting insulin levels. Fasting glucose isn't going to cut it. I think fasting glucose can be altered by the body too efficiently, and you may over-diagnose or under-diagnose a patient with sugar handling issues. So look at patient sugar levels. Magnesium, as mentioned before, great to improve serotonin, and it could also help to block this NMDA receptor, and could be one of the reasons why people take magnesium at night to help them sleep. The ability for serotonin to make melatonin, and then also we get a little bit of this blocking mechanism from this neuroexcitatory neurotransmitter glutamate. Zinc at 25 to 50 milligrams a day. Taurine's a mild antagonist of that receptor, but we're going to get additional benefit because it seems to improve the calming neurotransmitter GABA. So taurine could be something good. Pregnenolone is known as a neurosteroid. Pregnenolone can also make a lot of the hormones from the neck down, so testosterone, estrogen, progesterone, cortisol. Those are all bioconverted from pregnenolone. But pregnenolone has a tremendous activity in the brain, helping to modulate this NMDA, as well as also being a GABA agonist or a GABA mimic even. So 25 to 100 milligrams a day of pregnenolone. Curcumin, the dosage is going to vary tremendously. It depends on the form of curcumin, as well as whether or not it's combined with some synergistic nutrients. And ferulic acid is one of these that I don't hear about a lot, but I think it does a really good job. I used to use ferulic acid in just my athletes and bodybuilders to help with muscle recovery and endurance. But I am finding that, well, I was getting feedback for a while that they were taking it at night, which is fine, and they were noticing more restful sleep, and they wanted to know the mechanism behind that, and I didn't know. So I went out searching for it, and it seems that ferulic acid may have somewhat of a anti-inflammatory effect in the CNS, and actually can be an inhibitor of that excitatory receptor, NMDA, as well as maybe have some serotonin effects. Alpha-lipoic acid, this is one of the nutrients that kind of bothered me when I started entering into natural medicine, because it had so many great references and I never got any of the results, not even 10% of what the references would state. So I had to figure out why, because there's no way that this nutrient could be so researched with so many great outcomes, and I just wasn't seeing it. And the biggest thing that I found that I was doing wrong was I wasn't giving enough and I wasn't spreading it out throughout the day. Alpha-lipoic acid has a very short half-life, so it needs to be trickled into the system. And it needs to be a pretty good amount, so about 300 to 600 milligrams 3 times a day. I prefer lipoic acid on an empty stomach. It's an antioxidant, helps with energy pathways. It's an antiviral, especially for the herpes family viruses. As we talked about some of the cellular pathways when we first started, or the cellular constituents that are going to be affected in these chronic pain, and we talked about mitochondrial dysfunction. Of course, lipoic acid can help with mitochondria. And then there's some pretty good research out there about diabetic neuropathy, and alpha-lipoic acid actually improving outcomes even better than the analgesic drugs that are out there. And I have a local neurologist that if you enter into her office and you are on gabapentin, Neurontin, she will take you off it and she will load you up on lipoic acid because it works better, it's safer, and it's more effective. There's just some additional things alpha lipoic acid can do. There's some references. I wanted to add references specifically for lipoic acid for the very reason I mentioned a few minutes ago, that I found it to be underappreciated even by myself in the beginning, but it does work really well if you give enough and you spread it out throughout the day. So we're really getting this hypersensitivity because of this inflammation immune response. So what can cause that? Obviously, we have infections, but we can also have stress-induced neuroinflammation, small intestinal bacterial overgrowth. We talked about that with tryptophan being stolen to that kynurenine pathway. We can also have intestinal permeability, introducing these compounds that normally wouldn't be introduced into the bloodstream. Now they are. Once again, neuroinflammation, cross-reactivity, molecular mimicry, meaning some of these bacteria will create these proteins that will mimic a certain part of the body, let's say like myelin of the sheath of the nerve. And the immune system will properly go after the bacteria and that protein that they created, but they will also go after your nervous tissue at the same time because it looks very similar to that pathogenic protein. And we could see that with certain strep infections and psoriasis. There's a lot of this molecular mimicry being studied currently. Of course, mitochondrial dysfunction, and then hyperexcitability of the central nervous system, and that can come from aldehyde production, from the breakdown of neurotransmitters, from noxious smells. So perfumes and molds will give off aldehydes. Yeast gives off aldehydes. The breakdown of histamines will lead to this overt or increased aldehyde pool. Peroxynitrite, which is a nitrogenous oxidative stress on the body. Reactive oxygen species, so normal metabolism or some sort of inflammatory type response. Loss of blood-brain barrier integrity, so we talk about leaky gut, this is kind of leaky brain. Immune recruitment, and of course that NMDA or overstimulation of that neuroreceptor. NF-kappa B is a commonality that we see that would be increased in chronic fatigue syndrome and fibromyalgia, and this is just an intracellular protein that's part of the basically immune cascade or inflammation cascade within the white blood cell. So when we give nutrients to reduce NF-kappa B or nuclear factor kappa B, we are actually changing the disease process. We're not just giving someone an NSAID and saying, oh, this will take care of your pain, or here's an opioid. We're actually, from a cellular level, changing the way the body's creating these inflammatory intermediates. And increased NF-kappa B can lead to muscle pain, fatigue, low mood, and altered immune responses. And these are just some of the nutrients you can give to reduce NF-kappa B. I prefer to give some of these in combination rather than in isolation, but these all work pretty well. N-acetylcysteine. N-acetylcysteine has been used in animal models for traumatic brain injuries and cerebral inflammation, and it expresses a neuroprotective effect by increasing glutathione and scavenging free radicals directly within the central nervous system. And in this study, the rat brains had a reduction in cerebral edema, so inflammation, swelling, lowered lipid peroxidation, improvement in blood-brain barrier permeability, and reduction in neuro or cellular death. And the amount that they used was about 150 milligrams per kilogram, which gets you to about 9,500 milligrams a day for an adult, average human adult. In clinic, I think that's a bit much. Probably could be given safely if monitored, but the average dose we usually give patients is about 1,000 milligrams 3 times a day. Now, I'll get phone calls from patients, or not from patients, from other practitioners asking, what's your protocol? I have disease X. What do you give this patient? And it's such a difficult question because there are so many differences. There's so many factors to take in. What does the patient do as an occupation? What's their home life? What medications are they on? Protocols is not something we do, but there are some foundational nutrients you can use for these patients that suffer from central pain, this hypersensitivity, and that would be methylated B9 or methylfolate, acetyl L-carnitine, lipoic acid, omega-3, N-acetylcysteine, and CoQ10. Now, if you look at these, some people would say this is somewhat of a mitochondrial cocktail, and it pretty much is, with some additions in there. But we have your antioxidants, we have your high energy B vitamins, and things to help with fatty acid oxidation to improve energy status within the brain. I'm not sure if we have time to go through this patient case, but in detail. But just real quickly, a 61-year-old female. Her name was Vicky. Whole body pain came on suddenly during camping. She thought she pulled her hamstring by setting up a tent, picking up some fire logs. Eventually, it started to become more diffuse. What basically I wanted to stress in this patient case is you have to develop a timeline. If you develop a timeline with these chronic patients, more often than not, you will find the cause. So I go all the way back to birth. Were you breastfed, vaginal delivery? I mean, if they know that information, you know, how did you eat? Where did you go to school? Did you have any jobs when you were an adolescent? So on and so forth, to try and figure out where did things go wrong. Another great question is to ask your patient, when was the last time you felt well? So your symptoms may have came on 2 years ago, but when was the last time you really, really felt good? And oftentimes you will find that their symptom was really preceded by decades of feeling like crap. And that will give you some information too. Go back to that time, find out what changed there. Did you travel out of the country? Did you have a family member that died? Did you have a high stress relationship? What happened? What changed in your life that may have changed the chemistry within inside the brain that could open us up to having this central sensitization, this hypersensitivity to this external stimulus? So basically, we went through Vicky's case, and she complained of some gastrointestinal distress. She was treated prior to coming in my office for a dental surgery. She was given doxycycline, broad spectrum antimicrobial, and she said her pain actually improved. Stopped the antimicrobial, and the pain slowly started to creep back. So right then and there, I started to think of that neuroinflammatory cascade with serotonin. Ran some chemistries, found out she had some high inflammatory markers. Her CRP was 20 when she first came in. And that's a marker of inflammation as well as an immune marker. So we started on some treatment. So we started on emulsified oregano oil, berberine, and S-Boulardi. Emulsified oregano oil is a contact antimicrobial. Berberine to help. She had some sugar issues, so we wanted to help with the regulating sugar response, as well as an antimicrobial. S-Boulardi increased adherence of probiotics to the gut, improved secretory IgA levels within the gut, so improving the immune response. And then we're going to have basically microbial inhibition of growth of another microbe. So if we can get these S-Boulardi to grow really fast, they're going to occupy space or create like this bookmark within the GI tract. So these pathogenic microbes will die off. They'll have no more food source and no place to hang out. We did give her a combination anti-inflammatory product, and we gave her some magnesium to reduce that neuroexcitation at night so she can sleep. And on 30 days, patient's pain was decreased by 50%. Gas and bloating nearly gone. Bowel movements are normal. Energy up 25%. Her CRP went from 20 to 12.6, which is still high, but drastically improved. 12 months later, patient returned back to our office. So she kind of fell out of care, which some patients do. 12 months later, she came back. Her basically sugar status was normal. Iron status was restored without administering iron. So we assumed that those bacteria within her gut were actually gobbling up her iron, so her body couldn't absorb it. She was 100% pain-free, able to help her husband mow the yard, sleep through the night. But she did wind up going to Africa on a mission trip. She got the yellow fever vaccine, and within a week, her pain was back even worse, and her CRP is now up to 60, and now she has an anti-nuclear antibody that's positive. So she just kind of reactivated, if you will, as a patient. So it'll be interesting to see what we find out with Vicky. Other than mechanical injuries to the brain, we can have diet-induced traumatic brain injury, which a lot of people don't talk about directly. And this is the obvious, so there's no reason to belabor this. Low-quality protein, good fats, and low phytonutrients are a recipe for disaster. Disrupts the concert of endocrine hormones, reduces head-to-toe immunity, and creates neuroinflammation, leading to pain, fatigue, poor attention, low mood, and anxiousness. And if we switch this biomedical model to a biopsychosocial model, you will start to expose the reason why these patients feel this way. Old pains, fears, past memories of trauma, social environment, physical activity will all change the way the patient's pain's threshold and how much pain the central nervous system can handle, or why it's interpreting it incorrectly. And apologize, I went